Hi, this is Nick Morris for the NCS podcast. We are live at the annual meeting, and we just finished the non-invasive ICP session. I'm here with Dr. Mohammed Hirzallah from Baylor College of Medicine, who really gave a wonderful talk on optic nerve sheath diameter. And it was clear to me that Dr. Hirzallah has probably thought more about optic nerve sheath than just about anyone I've ever met. And I thought it would be wonderful to have him on the pod. So welcome, Dr. Hirzallah.
Thank you for having me.
Great. Now, I think a lot of us employ optic nerve sheath diameter as a sort of easily obtainable, non-invasive ICP measurement, but no one's quite clear on what the proper cutoff or threshold should be for determining high ICP. And you did a wonderful job in your talk in explaining some of the reasons why we don't understand this. Can you summarize those?
Yeah, absolutely. So the first point, the cutoff. The cutoffs are tricky because the meta-analyses often allow studies to use their own cutoffs. So you'll see cutoffs as low as 4 millimeters and others as high as 6.5 millimeters. So that's a huge variation. I would say a good rule of thumb is above 5 in someone that is unconscious, you likely have CT changes. Um, Above 6 is a higher probability that you have ICP changes. So kind of use your pretest probability to adjust the cutoff. So if you have a high suspicion, use 5 millimeters as a cutoff. If your suspicion is low, I would use 6 millimeters as a cutoff.
Great. And you pointed out in your talk some of the technical factors that vary from study to study. In fact, some studies you pointed out didn't even measure the optic nerve sheath at all. They actually measured just the optic nerve. Can you kind of go through some of these factors and what we should be thinking about and aware of when we're getting these measurements?
Yeah, absolutely. I think part of this is maybe we need to upgrade how we do this measurement, right? If I come to you and say I have this thing called echocardiography, and I'm not exactly sure, but anything from an ejection fraction of 30% to 60% might be abnormal, no one would use it, right? So we need to kind of start becoming more rigorous about how we do the measurement. So think about where you place your probe and really making those small adjustments with your probe until you get a nice cut with that thin interface between the nerve and the eyeball and the clear anatomic differentiation between the subarachnoid space, the nerve, the dura, and the retroorbital fat. You need to see those clean lines. And when you're doing that, remember you're scanning a 4 to 6 millimeter structure, right? So that's maybe thinner than a pencil. And so when you are moving your probe around, these are really small adjustments to get that longitudinal cut through the nerve. So once you get that nice image, then understanding the anatomy and placing the markers correctly is going to be the most impactful thing to get an accurate measurement.
And you mentioned some studies clearly are not all using a linear probe. Your recommendation is, right, to always use a linear probe?
Yes, so classic ultrasound teaching is linear probe for more superficial structures where we need resolution, and then your phased array or your curvilinear probe for when you need deeper penetration with less resolution, right? So linear probe is for this use case. So we care about that accurate lateral resolution, so you should use a linear probe. At least 7.5 megahertz, probably closer to 10 is ideal.
Great. And my trainees often know that they should be measuring 3 millimeters back, but they don't always know back from what. So
Exactly.
what is your recommendation for that?
So that was one of the big sources of variations. So you see some studies measuring from the papilla, even with papilledema, right? So if your papilla is already 1 or 2 millimeters elevated, you're barely getting to the optic nerve sheath if you only go 3 millimeters from that. You have studies measuring from the retina, and you have studies measuring from the sclera or behind the eyeball. So the retina seems to be the most consistent structure that people agree on. It's also easier to spot because of that echogenicity difference between the retina and the rest of the eyeball. So I would say retina, you place your line right at that echogenicity change between the hyperechoic retina and the hypoechoic vitreous fluid. Place your marker there, go 3 millimeters depth along the axis of the optic nerve, right? So if your image is tilted, you need to adjust that depth marker, and that's where you perform the measurement.
Great. And then you mentioned in your talk that there can be great variability in the measurements from the interior aspect of the optic nerve sheath versus the exterior aspect. And so what do you recommend we measure?
So and this is one of those things where I'll try to be descriptive to kind of convey an image with words. So the innermost structure, that hypoechoic line, that's the nerve. Then you have two structures outside of that, and people describe them as the stripped hyperechoic bands. So they're like horizontal strips, they're hyperechoic, and they surround the nerve. That's most likely the subarachnoid space. Then you have the outer black line outside that, so an outer hypoechoic band surrounding that, that's most likely the dura. Then you have the retroorbital fat that is hyperechoic. And that's the challenge where it's important to get that nice resolution, because the echogenicity of the subarachnoid space and the retroorbital fat can be very similar. So you need to get that nice line in between. Now, the difference between internal and external is whether you place that marker inside the black line, which is the dura, and you measure the inside diameter of the optic nerve sheath, or you place that line outside the dura, and then it's the external diameter of the optic nerve sheath. And the reason that's important is they vary by around 1.5 millimeters. So, and that's a statistically significant difference in some studies that we showed today, right? So that would be the challenge, is if you're not measuring the same structure consistently, you will get variable results, and then your measurements are not accurate.
Great.
Both measurements are sensitive and specific for elevated ICP. So whichever measurement you do in your practice for now until we have standardization, just make sure that you're making that same measurement.
Great. And lastly, I don't think you mentioned it in your talk, but we've seen papers looking at what is the right plane to look at the optic nerve in, and some papers suggest that we should be looking in multiple planes and taking an average. What's your practice?
So yeah, we didn't mention that in the talk, but we discussed it extensively in the panel. So there are the planes that are published so there is an infraorbital plane that almost tries to get a cross section that is not feasible in all people. Then the more common planes that we see is the axial or the coronal plane. There are studies that compared them, and a lot of the times they don't correlate, but those weren't very extensive studies. Most panelists prefer the coronal axis. Also, from just a logistics standpoint, unless you have a specialized small footprint probe, it's really hard to fit that over the eye if you're going coronally. So that's why most people prefer axial. And the classical measurements that were first performed were axial. A lot of our normative databases, the good studies that kind of give you the normal values, also used coronal. So it seems like most people prefer coronal, and that's the one I would encourage people to use for clinical applications. But if you have a research application where you want to investigate different axes against each other or average them to see if that improves the measurement, that's valid, but the standard is coronal.
Great. And then lastly, you mentioned it, but we haven't explicitly said it. So the panel that you're describing, can you tell the listeners who that is and how you're working with this group in order to standardize these measurements?
Yeah, absolutely. So the panel is right now 60 panelists. We have 10 steering committee members, and these are people that published on variability and how to improve the measurement. And then together we reviewed the literature and we classified the sources of variation. Then we recruited our expert panelists outside the steering committee, so those are 50 panelists. And we had selection criteria for our panelists. So we picked the most published optic nerve sheath diameter experts by number of publications. We reached out to them. We reached out to education experts, basically ultrasound fellowship program directors, and asked them if they teach optic nerve sheath diameter frequently and if they'd be interested in participating. And then we asked them to nominate clinicians that use this measurement in their clinical practice. So we tried to keep it balanced between clinicians, educators, and researchers. We have 50 panelists: Canada, US, Latin America, Europe, Africa, Middle East, and China. So it's a diverse panel.
Great. Well, thank you so much. I'm really excited to see what this panel produces, and I think it will go a long way into standardizing this practice so that we're all on the same page when we talk about optic nerve sheath diameter and its relation to ICP. So thanks for your work, and we look forward to seeing the eventual publications that will come from this.
Awesome. Thank you for having me.
All right. Thank you. Thanks everyone for joining us here on the Neurocritical Care podcast. It's available anywhere you get your podcasts, and it comes along with some continuing education credits, so check it out. This is Nick Morris, live from the annual meeting.